Can you hear me all? Okay, fantastic. Welcome everybody to the office hours, infectious disease office hours for March 29th. My name is Joanna Katzman. I'm a neurologist at Project ECHO and UNM, and I'll be facilitating today's session. I think we have Dr. Sosa, Dr. Hayes, Marla Sievers, and hopefully also Dr. Carissa Culbreth on today. Wanted to welcome you all back. Thank you so much for your great participation. I see so many faces on the line, and if you have a video camera and don't have that turned on, it is perfectly all right to eat and drink. For many of you, it's your lunch hour or break, and perfectly fine to do that while your video is on. Just a reminder that Kent Noseworthy is our digital librarian, and he'll be putting just so much information in the chat, evidence-based, evidence-guided material that you can copy and paste and save that for later on, put that into your own browser. At 45 minutes after the hour, we'll have the CME link for you. And even if you do not need CME or CEU credits, it's always great if you can fill that out so that we can know how we're doing and improve this program very thoughtfully as we meet every week. Finally, the slides. We've been happy to be able to get the slides to you each week, and Elena Martinez will be able to post that into the chat during the session as well. So without further ado, I'd like to introduce Dr. Nestor Sosa, who's our chief. He leads the infectious disease service at the University of New Mexico School of Medicine. Dr. Sosa.
Can you hear me well, Joanna?
Nestor, I can hear you really good.
Okay, perfect. All right, so let's get started. Okay, so the first paper that I want to present is somewhat of a surprise to me. I saw in the news a communication of this drug, proxalutamide, which is actually an androgen receptor inhibitor, a novel androgen receptor inhibitor that had been studied for metastatic cancer. And well, you will see the news. It showed like a dramatic 92% decrease mortality for COVID in a headline. So I was curious about this drug, and I wonder if it's a new hydroxychloroquine that is going to be deflated when we see the paper, or is it really the magic bullet that we've been waiting for? So let me show you some of the data. So this was the news. This appeared in the European Pharmaceutical Review, which is like an online news outlet, and the headline says it all. Proxalutamide reduces COVID-19 mortality by 92%. You know, taking into consideration that remdesivir reduces the mortality by 0%. This is 92% better, right? At least the headline. So what they reported in this was the preliminary result of a phase 3 trial in Brazil, in 12 different sites in Brazil. And this study, according to the news outlet, is a double-blind, placebo-controlled, so well-designed study in different sites in Brazil with, you know, around 600 patients grouped in 2 cohorts, because this is an androgenic. They wanted to study in males and females separately. But overall, they found that the 14-day mortality of this patient was extremely low, 3.7% versus extremely high in the placebo group, 47.6. So almost too good to be true. And the hospital stay was shortened by almost 10 days, 5 days in the treatment group, 14 days in the placebo. So that's all the information. They gave the name of the 2 investigators. I look at the clinicaltrial.gov, and in fact, this trial is listed there, and presumably the result is going to be available. Complete result is going to be available in April, according to the clinicaltrials.gov. So that was interesting. So I look even further, and I found this article by the same author, Flavio Cadegani and Andy Goren, who actually published a smaller study, also double-blind placebo, of Proxa accelerating viral clearance and reducing time to clinical remission. This was published in February in an online journal. The way, and you may be asking, as I did, what is an androgen receptor blocker, doing in a COVID trial? If you remember, and this is sort of reviewing a little bit of the basic science, for the virus to enter the cells, it needs the ACE receptor, which we know is the well-known ACE2 receptor. But in order to attach to the ACE2 receptor, there's an enzyme, a serine protease called TMPRSS, or TMPRSS2. TMPRSS actually modifies the spike protein and makes it more available for the ACE receptor to be able to join. So these two are key for the entrance. And it turns out that androgen actually is the only known promoter of the production of TMPRSS in the nuclei, TMPRSS mRNA and then TMPRSS protein. So theoretically, blocking this activation of TMPRSS production, there are going to be less TMPRSS in the cells and thus less entry of the virus into the cells. So that's like the leading hypothesis. And the study that was published, this is the one, not the one from the news, but the published study was a double-blind, randomized, placebo-controlled, 236 patient adults with positive PCR, mild COVID, less than 3 in the WHO scale. So patient, basically ambulatory patients, and they were offered the proxalutamide 200 milligrams for 15 days or until remission of symptoms, or placebo, or a matching placebo. And they found a faster clearance. 82% of the patients in the Proxa arm had cleared the viral load in the throat versus 21%. And there was also a significantly shorter time to remission, 4.2 days recovery for the Proxa versus 3 weeks, basically symptomatic for the placebo. So this was the basis for the large trial that I saw in the European news outlet. So we have to wait. I think we have to wait for the publication of the phase 3, but it certainly looks promising. This is not a retrospective trial like it happened with the hydroxychloroquine. This is a placebo control, so at least it's better designed. So we really have to wait, but it's really impressive the way this drug seems to be working. Let's see what happens when we do larger trials in multi-center, multi-country trials with these new. It's a non-steroidal androgen receptor blocker. Okay, so that was interesting. And then from the fancy new drug to a really old drug, aspirin. This is, I think, one of the first studies actually testing aspirin in COVID. This is a retrospective. It was a retrospective study out of centers here in the U.S. in which they look at the patients that were admitted and given aspirin, either because they were receiving it before or because they had some indication for aspirin, and they compare retrospectively the in-hospital mortality, intensive care unit admission, and mechanical ventilation. And they actually found that those 3 markers were significantly reduced in those who were given or were started on aspirin in the hospital. And this is not a prospective trial. Again, this is a retrospective chart review, so there's a lot of limitations, a lot of variability between the two, the treated and untreated subjects, or the aspirin and non-aspirin subjects. But it was interesting and intriguing finding. And obviously the explanation that the authors postulate for this effect is the fact that we have seen pulmonary complications associated with thrombosis in the microvasculature of the lung. So it makes sense that, we already have seen that anticoagulation or prophylactic anticoagulation helps. So this antiplatelet agent may also help in this process. And this is basically the forest plot of indicating mechanical ventilation, ICU admission were all better or less risk of having these 3 outcomes if you were in the aspirin arm than if you were in the non-aspirin arm. And these are the reduction, more or less a 50% reduction of all across the board for these three risk factors. And the Kaplan-Meier survival curve, also mortality benefit for aspirin, the blue, and the yellow are the aspirin and non-aspirin respectively. So interesting. This is a retrospective trial. We need to do a prospective trial now, a large prospective trial, to see if really, this simple inexpensive, readily available drug like aspirin can make a difference in the patient severity. I presented last week the study on the 3 feet versus 6 feet opening of school, and I criticized a little bit the methodology. So I was glad to see that there were 2 publications in the latest MNWR with much more data, real life data on opening schools. One of these, and it's sort of a lengthy, complicated study, but they actually look at the data from Florida. Florida actually opened schools in the latter part of last year, and what they demonstrated in this study, which was sort of a study of all the schools that opened in Florida, was that while they had an increased number of total cases, these purple bars reflect total number of cases in Florida. There was not a significant increase in the cases in children 5 to 17 and school-related, what they call in this study, school-related cases in children, also 5 to 17. So you can see both lines, blue and the dotted blue lines, are flat as opposed to increased cases in the community. So the conclusion of the authors of this MNWR is that despite the opening of the schools, there was not a significant proportion of kids affected as a consequence of that. Although there were cases, obviously school-related cases, and there were, outbreaks in some schools and closures of schools because of these outbreaks. But overall, if you look at the whole state, it was not significantly impacted, and actually only 1% of the kids in the whole state became infected from a school-related case. So that is somewhat reassuring. And then there was a smaller but much more intensive study in Utah, in which they actually found low SARS-CoV transmission in elementary schools in Salt Lake City. They actually studied 20 elementary schools in depth. They did like really, really close contact tracing and even genomic studies to see relatedness. And they actually found a very low secondary attack rate for the cases in schools, only 0.7%. If we compare it, the attack rate in a home is like 22 to 30%. So this is really, and these were schools that were using only 3 feet apart, and obviously we're using masking and suppressing some of the extracurricular activities. So it was sort of taking several of the precautions that are recommended, but definitely very successful outcome with only 0.7% secondary attack rates in these 20 elementary schools in Salt Lake City. And this is also very well designed study. So I think with these 2 studies plus the one in Massachusetts, I think there's enough science to at least with some precautions open the schools, and that's sort of the conclusion and what I think is going to be recommended moving forward. I just one of the big questions that we still have with the vaccines. Obviously, the vaccines are excellent preventing severe disease, practically all of them. But the question that is still lingering is, can the vaccines prevent asymptomatic transmission, which is actually a surrogate marker for, as asymptomatic infection, which is a surrogate marker for transmission. And there's more evidence. I have presented before some evidence to that. This was a study published in Clinical Infectious Disease, Impact of COVID-19 Vaccine on Asymptomatic Infection Among Patients Undergoing Pre-Procedural COVID-19 Molecular Testing. So this is in the setting of a healthcare system. I think it's the Mayo Clinic. These authors, because they do PCR testing on everybody who's going to have surgery or general anesthesia or some other procedures, they actually capture the moment when some of these subjects were vaccinated a few days after vaccinations, and others that were not still vaccinated, and they compare if those vaccinated had less or more infections, asymptomatic infection, because these were basically detected by PCR without symptoms, and they found overall, after adjusting, that right before they got the second dose, there was an 80%, so only with 1 dose of the Pfizer vaccine, in this case, 80% reduction in asymptomatic transmission. So very good, reduction overall of asymptomatic transmission in this retrospective cohort study, which is similar to what we have seen in other publications. at least with the mRNA vaccines. And this is, as I said, only right after the second dose. So it's probably even better if you wait the full 2 weeks after the second dose, which is when the CDC considers that you are fully vaccinated. So, promising. Although you can, if you're a pessimist, you can say, okay, there's still a 20% transmission at that time. So yeah, it's true. There's still some transmission, and that's what we are emphasizing, that even if you're vaccinated, you have to still take some precautions, but nevertheless shows that a decent prevention of asymptomatic disease, and thus probably impact on transmission. The other big question that we have been asking, and it's something especially the patients that are suffering from long COVID, and now long COVID has I think they're working on this official name, post-acute sequelae of SARS-CoV-2 infection, PASC. So that's how I think the final nomenclature of the long COVID is going to be PASC. I just learned that over the weekend. So the question is, are vaccines safe in patients with PASC? And there was one publication, and we have made this comment before, but there's one publication precisely addressing, are vaccines safe in long COVID? It's a prospective observational study. This it's out of Bristol in the United Kingdom. They had a cohort of patients that were initially hospitalized with COVID and were left with basically with long COVID. They had been followed at 3 months after hospitalization, at 8 months, and they have persistent symptoms. And they were vaccinated, like many other people in the UK were vaccinated. So they took a sample of 44 vaccinated long COVID patients and 22 that had not been vaccinated, and they compare what happened to their symptoms overall, to their quality of life using this SF-36 score, and a mental well-being also score used in the UK, and they evaluated and see 1 month after vaccination for those vaccinated, or a similar time for those unvaccinated subjects. They compare, and the good news is that, number one, among the unvaccinated, more people, more subjects have worsening of the symptoms than the vaccinated. So the vaccinated deteriorated less or had less persistent symptoms. And in fact, there were more resolution of symptoms, 23% in the vaccinated versus 15% in the unvaccinated, and no significant differences in the score. So at least we can conclude, at least from this small study of just 44 and 22 subjects, that the vaccines didn't make them worse, and if anything, improved some of the symptoms in some of them. And you can actually see it graphically here. So worsening symptoms is in yellow, unvaccinated on the left, vaccinated on the right. You can see there's more yellow on this graph on the unvaccinated than the vaccinated. Actually, a couple of the vaccinated symptoms improve, and also more improvement, more blue on the vaccinated than the unvaccinated. So interesting, at least the first evidence that people with long COVID or patients with long COVID can actually be vaccinated safely, and if in some cases they may even improve their symptoms. And just to finalize, only one article on variants. I always try to bring these variants, but unfortunately, this is an article, a very negative article in the results. It's an article from Brazil, and as you know, Brazil is experiencing right now a very huge surge with a lot of mortality. And the worrisome this paper was really worrisome, is sudden rise in COVID-19 case fatality among young and middle-aged adults in South Brazil after identification of the P1 variant. So what they did, these authors actually looked at the mortality or case fatality rate of SARS before, so in January, and how it changed when the new variant was actually introduced in February. And you can see, I put a red square to highlight the most important finding. In those age 20 to 29, 30 to 39, 40 to 49, and 50 to 59, there is an increase, a significant increase, triple or double increase in the case fatality ratio for those group of relatively young subjects. So and this is apparently blamed on the variant, basically, because they actually look at some parameters to see if they could find an explanation. This was obviously statistically significant. So there was an increase in all of the groups, but it was more marked in the 20 to 59. And you can see this is the case fatality rate in the less than 50. And you can see that how, in some groups like this 40 to 49, 30 to 39 naturally increase the case fatality rate in all the groups, basically, but it was more marked in those younger group. And this cannot be explained by an increase in the number of cases and like overwhelming of the health system, because precisely when that peak of case fatality rate here in red occur, the cases were coming down. So this cannot be blamed on lack of oxygen tanks or lack of ventilator, because it was actually sort of in the downward trend of the curve. And when they notice this increase in the number of fatalities, especially in this younger group. So really worrisome news from Brazil, and we're seeing in other places where this variant is becoming more prevalent. At least anecdotally, they're describing a higher mortality even in younger patients. So something of concern. Okay, that's it for me today. Thank you.
Nestor, I think you covered almost everything that I can think of and more. So thank you. We have lots of great questions that I think we'll wait till we get through all the presentations. Next up is Leslie Hayes, our primary care and addiction expert from Española.
Hi, Leslie Hayes here. And I had a couple patient issues come up last week, and it took me forever to come up with an answer to them. So I thought it might be something other people were coming across. The first was a 70-year-old woman, or woman in her 70s. She was exposed to a family member who was positive for COVID. She has a chronic cough, and she stated it was a little bit worse, but she pretty much felt fine. She'd received the first Pfizer vaccine in January and the second in February. She was positive for COVID by both the rapid antigen and the PCR test. Her risk factors included diabetes, hypertension, and age. And I was like, do I offer her monoclonal antibody, even though she has had the vaccine? And I wasn't sure. Nobody in the clinic was sure. And it took me quite some time to find it. I eventually called Carla, who confirmed my answer. And the CDC basically says yes. If you go to their page on vaccination, interim clinical considerations for use of COVID-19 vaccines, they state for vaccinated people who subsequently experience COVID-19, prior receipt of a COVID-19 vaccine should not affect treatment decisions, including use of monoclonal antibodies, convalescent plasma, antiviral treatment, or corticosteroid administration, or the timing of such treatments. So I did refer her, and I don't know if she has gotten it yet. And then this one I was not able to actually find a good answer to, and I made Nestor and Marla promise that they would give an answer, because I couldn't find the full answer. Do fully vaccinated people still need to quarantine for URI symptoms with negative COVID testing? So this was a woman in her 60s, fully vaccinated, came into the clinic for routine follow-up. I asked her how she was doing, and she said, "Oh, I feel fine, other than I've had nasal congestion and sore throat and a mild cough with some swollen lymph nodes for 3 days." COVID rapid antigen was negative, PCR was negative. So the question was this person still need to isolate? And I scoured Google and the CDC website, and I could not find an answer anywhere. I looked at maybe somebody better than me at Google can find it, but nobody answered this specifically. And what the CDC said was you should still watch out for symptoms of COVID-19, especially if you've been around someone who is sick. If you have symptoms of COVID-19, you should get tested and stay home and away from others. But they did not answer what happened then if that testing was negative. So my gut feeling was in a green county with a vaccinated patient and really pretty vague symptoms. I didn't feel she needed to quarantine, but I was hoping to get some input from people who are smarter than me about this. And then next, I don't know about the rest of you, but I keep having patients come in saying, well, I don't want to get the vaccine yet because they're only giving whatever. I want to get specific vaccine. And it's always something different. And this is really a wonderful article. And this would be one I would encourage people to actually read, because it really specified why we cannot compare the vaccine trials. And they said that multiple variables between the trials that make them hard to compare. And the randomization is intended to assure comparability of groups within the trials, but it doesn't do anything for comparing between trials. So there's variations in the study populations. Some trials excluded patients with pre-existing conditions. And for instance, Novavax reported that their vaccine was not as efficacious when they included HIV-infected individuals. And the Oxford AstraZeneca trial found that they had good efficacy in patients who received a half dose in the initial immunization, but this was only for people age 18 to 55. And so obviously that's important. Seropositivity status. Initially, the mRNA vaccine trial in the Oxford AstraZeneca excluded participants in their primary analysis who were either seropositive at baseline or without baseline serologic results. And people who are seropositive at baseline will likely be factored into future trials, but right now we don't know for sure the answers on that. And then presence of variants obviously is going to have a huge effect on the vaccine efficacy. Intensity of epidemic may have contributed to the differences in efficacy. The number of infectious challenges and how high an inoculum virus people are getting may be higher in places where the population density is greater or the epidemic is more intense. Non-pharmaceutical measures such as masks may have had an effect. Case definitions vary, and then looking at asymptomatic, mild, moderate, severe, and critical, what they found was the definitions really differed between the trials. And I forget which one, I think it was Moderna actually gave people in their trials an O2 monitor to take home. And what they found was that there were a higher number of people with low O2 sats in the Moderna, which was not surprising because they were measuring that. And then there were also different criteria for testing in the trials. Testing with milder symptoms is going to identify more cases. Some of them tested only for more severe symptoms. And one thing to realize is while the efficacy results have varied for any symptomatic disease, the efficacy results against severe disease have been pretty robust for all of the trials. And then they also said as standards of care improve, people are going to be surviving longer. So as we get further and do more vaccine trials now, the mortality is going to be less in the trials. And then I thought this was really the most important point, and I actually quoted them directly on it, that the ultimate success of a vaccination program is measured by the ability to prevent disease and not by individual efficacy. In some ways, we don't care how much it prevents disease in any individual. We want to make sure it's preventing disease in a population. So vaccines that are moderately efficacious against disease and able to reach large segments of the population because of greater supply, single dose formulations, improved delivery characteristics, or greater acceptability will yield substantial public health gains. So I thought that was probably the most important thing that I got from this article, but it was, I thought, a very interesting article. And then lastly, this was just my favorite headline this week. New Mexico's COVID-19 vaccinations are outpacing new infections 72-1. So, and I thought that was pretty cool. And that's all I have.
Thank you, Dr. Hayes, so much. We now have Marla Sievers, who's one of our state epidemiologists working primarily on the COVID pandemic. Marla has some vaccine updates for us.
Hi, thank you, Joanna. Hi, everyone. I wanted to give a vaccine update. This question came up last week and I answered it, and there's been some changes since then. So we are currently on track in New Mexico to open up vaccine eligibility to everyone age 16 years of age or older next month in April. So our continued progress towards this goal obviously is dependent on the weekly vaccine allocations we receive from HHS. But things are looking positive that we'll be able to expand the vaccine eligibility even more and open it up to everyone who'd like to be vaccinated by next month. So I wanted to just take a moment to recognize the efforts of our vaccine program, the vaccine planning group, the National Guard, our pharmacy and FQHC partners, and our hospital and healthcare system partners that have really made this successful rollout and this progress possible. The collaboration among providers and the public-private partnerships in New Mexico have really been outstanding. One other update, starting this week, people age 75 and older no longer need an event code to be able to register at a vaccine site, so to get an appointment at an event. Lots of feedback from partners and the community about how difficult it has been for those older adults to respond quickly enough to that event code to be able to secure an appointment, because the events, tend to fill up within a few minutes of the announcement. So people age 75 and older will no longer need an event code. They can log in to their profile. And if they meet that age criteria, we'll see, just using their confirmation code, events at times and locations in their area, and they can choose the site and the time that works best for them. So hopefully that will be an enhancement that will allow us to reach more of those folks that have had a lot of difficulty getting into those vaccine events. And so we continue to work with the Aging and Long-Term Services Department and the UNM Office of Community Health to also help overcome some of the technological challenges for those groups, get them registered by phone, connected to vaccine sites in other ways. And then lastly, I just wanted to mention there was an MMWR published today on interim vaccine effectiveness, preventing SARS-CoV-2 infection among healthcare personnel and first responders. So this is a study that involves 8 US locations. It's the HEROES Recover study. It's a longitudinal cohort study that started in July of 2020. And the vaccine effectiveness portion of that study began in December 14th. So when vaccine first rolled out to frontline healthcare personnel and extended through March 13th. And the participants in this study filled out a weekly symptom profile and also were swabbed weekly looking for SARS-CoV-2 infection. And there were about 4,000 participants in this study that were included in the final vaccine effectiveness analysis. So more great news about vaccine. 63% of the people in the study received a Pfizer vaccine, and that just really has to do with the timing of that vaccine being rolled out first and these folks being in group 1A and being vaccinated very early. But what the analysis found was that people who are fully vaccinated in this group, so more than 2 weeks after their second vaccine, there was a 90% reduction in infection. So this is not just symptomatic illness, but actual SARS-CoV-2 infection among fully vaccinated folks. And people who had received 1 vaccine and were at least 2 weeks past that initial dose were 80% less likely to become infected with SARS-CoV-2. So this is great additional information about the effectiveness of vaccine to prevent infection and therefore both symptomatic and asymptomatic transmission. Thank you.
Thank you, Marla. Fantastic. I really hope that these great vaccine studies can be highly, publicized to get those that are a little bit hesitant or on the fence to really want to get vaccinated. Thank you, Marla, so much. There's one question, Marla, I wonder if you might address. That was from Dr. Eva Angeli, who works on the inpatient side at UNM. She says, when might we see vaccinations available for hospitalized patients?
So I think, if patients are hospitalized for a reason other than SARS-CoV-2 and they don't have some other contraindication to vaccine, there's no reason that people who are inpatients could not be vaccinated now or vaccinated prior to discharge.
Thanks, Marla, so much. And we'll come back to you if we can for questions in a moment. I just want to briefly introduce Dr. Cecilia Thompson, who works alongside Dr. Clarissa Culbreth at Tricor Labs. Cecilia, are you there?
Yeah, I'm here. I don't have any updates or announcements, but I'm happy to take any questions regarding testing.
Fantastic. Thank you, Cecilia. I'm going to just move to the top of the chat questions. We've got a ton of questions today, and I want to get started right away. The first is from Dr. Hayes, and it relates to Dr. Sosa's the first study, which was the study related to I can't pronounce that first drug, Proxalutamide. Yeah, yes, something like that. And
Proxal, let's call it Proxal.
Okay, good. And Leslie said, is androgen affecting the TMPRSS too at all related to why men do poorly with COVID?
It could be. I don't know. It's probably one of the reasons. Yeah.
Right. Irene Shower says, but I think that men would do much worse than women if this drug really helps that much. So really good point from Irene. So Diana Rodriguez Hurtado, one of our partners in Peru, asks, what is the dose of aspirin? And Nestor, I believe it's 81 milligrams, Nestor? I think you're muted. Nestor.
Sorry, it was retrospective, so they didn't give those, but when they look back, the median dose was 81, right? So it was like a baby aspirin or small aspirin, exactly, what most patients were receiving.
Thank you so much. Okay, great. So, and it's interesting given the relationship with the clotting and vascular diseases as well. So then we had a number of questions regarding the schools and interesting regarding the data from Florida and Utah, Dr. Sosa. And Peggy Spencer says related to these school studies, but how do they know that kids weren't asymptomatic spreaders? And Dr. Harry Seibold kind of asked a similar question. Do you have any ideas about that, Nestor or Leslie?
Yeah, in the case of Utah, which was a more detailed, more interventional study, they actually tested all the kids that had contact with a positive case, regardless of symptoms. So they did a real, like, intensive contact tracing, isolation, and in those positive, they even do genomic studies to make sure that the strain that they got, the secondary cases got, was similar to the original case. In the case of Florida, was more of a general data type of thing. I mean, they look at the number of cases in the state, the number of cases in kids in certain age, and they call school-related cases to to patients who have been in school and became infected, but in fact they were not sure. Some of those cases could have happened in the community, but they generalized it to make it easier to analyze. But in the Utah, they did the whole thing, even genomic-wide studies to establish relatedness of the virus in the outbreaks.
Fantastic. And so it sounds like Dr. Seibold is asking, did they trace back and see if there was increased transmission in families? And it sounds like they did that.
Yeah, they did, and they found some secondary cases, especially in the Utah. They found secondary cases at home, definitely in some of those transmissions. But the message was that transmission in school was lower than in the community, and the attack rate was lower than what had been described in other settings, like congregate settings, nursing homes, even family, regular household transmission. It's much higher than the 0.7% attack rate, which is very low. And actually in the Florida was interesting because they were able to, they tried to see the settings where the transmission occurred, and there were some outbreaks. I mean, there were outbreaks and even school closures, and some of the largest outbreaks were related not to the school's activity, but to the sports related to school activity. There was like an outbreak of 56 cases related to a wrestling match, and very high numbers, and also with football, 17, I think, and 18 cases were the number of cases in the outbreak. So obviously extracurricular activities, social gatherings related to school opening are risky activities, more than the being in the class 3 feet with the mask. That seems to be less of a risk than the other things that occur around school, like sports and social gatherings. And they point out to that in the paper.
Thanks, Nestor. Very interesting as we, get back to school. Thank you for that. Dr. Lawrence Carrion says, any reports of increased rates of multi-system inflammatory syndrome in Florida and or Utah, and that the CDC reported over 2,500 cases in the US before March with 33 deaths. I think Lawrence, you're alluding to the fact that as school goes back into session, might there be more cases of MIS?
Yeah, in these two papers, they didn't address MIS at all. I mean, these were epidemiological, not clinical cases, so they didn't make any specific comments. I have heard, obviously, of more reports of MIS in some states, but this is anecdotal in podcasts and things. People are, as I said, I think previously, that they're paying more attention to the younger groups, because now they are the unvaccinated. In some states will be the unvaccinated or vaccinated at the end. So we're probably going to be, at least we're going to pay more attention to cases in kids, multi-inflammatory symptoms in kids, and even outbreaks in schools and other where younger people congregate because they're not vaccinated, basically.
Thank you, Nestor. And I'm wondering, does the Brazilian variant seem the most severe right now in terms of increase in morbidity or mortality, or is because the case rate is so high in Brazil and it is so transmissible right now. Is that why perhaps it seems like it really increases the morbidity and mortality? What are your thoughts on that, Nestor?
Right. I mean, there are some publications also about the UK variant being more problematic, I don't want to use the word lethal, but more severe. So yeah, at least these two variants have some publication. This is the first one that I've seen on the Brazilian. I mean, there were a lot of anecdotes. I have some Brazilian friends that are making the anecdotal comment that, oh, my ICU is full of young people now. I didn't see this in March. So those type of comments, but this paper definitely supports those anecdotal reports that they're seeing. In fact, I can tell you the anecdote, and this is something that it's of public knowledge in my country, in Panama. They reported the first case of the Brazilian strain, and it's a family of 3, and 2 are in ICU. And these are young people, in their 30s. So the husband and wife are in ICU. Only the 5-year-old kid is not in ICU. It's doing okay. But the 2 parents who went to Brazil and came back to Panama are both critically ill, and they are healthy, young, young couple. So it's really striking the severity of these disease.
Nestor, could you tell us about the vaccine? How are the vaccines working against this variant? I think you're muted, Nestor.
Okay, let me just share this. Can you see my slide?
Yes.
So this is this was a study actually. I think it's in the pre-publication, but they took patients or subjects that had received the mRNA vaccine, 1 or 2 doses of the Pfizer or Moderna, and they actually this is more of a like illustration more than this result, but these are sort of the neutralization effect of 1 dose in pink, 2 doses in red, to the different variants. So you can see like all the way up to probably the California strain here, the 429, the neutralization is pretty decent, okay, for the vaccines with all these strains. So this is the wild type, the Wuhan original one, the D64. This is the UK in purple. This is one of the California variants, the 429. But then when you start going into the Brazilian, these are the 2 Brazilian strain, P1, P2. This is South Africa. They're really low. They're almost as low as the neutralization effect over SARS-CoV-1. So the 2002 and other wild coronaviruses. So really, the neutralization power of the vaccine seems to be lost with P1 and with the South African and the Brazilian for short. So that is what we know, that there's definitely a drop, but this is obviously neutralization is not taking into account T-cell response. This is always the caveat, and it's not a clinical study, so you can still have prevention of severe disease even if you had this variant, but we don't know. We have to wait, for instance, the data from Brazil or South Africa with the mRNA vaccines and see if they're protecting against severe disease. But at least from the laboratory standpoint, there's a significant drop in the neutralization capacity of the serum of those vaccinated against this new, especially the P1 and the South African strains. Okay.
Thank you, Nestor. Do you know, I know I'm just asking you questions, but I think people want to hear this. Are these strains being looked at readily in New Mexico and throughout the US right now? Do we know where it's, what the rates are of this variant?
I don't know about the variant. I mean, it had been reported like sporadically in several states, and here in New Mexico, at least, we do have a pretty strong group working on doing genomics. I mean, so and I see Cecilia is doing. We have Daryl. We have the 2 Daryls here at UNM. We have the people at the national lab supporting and DOH. So I think we are looking, at least in our state, we are looking for variants, and they do. I have seen this beautiful graph with the different variants circulating in New Mexico. So we're monitoring that. I don't know if Cecilia wants to add anything, because I saw her, she was nodding, and I think it's important.
Yes. Thanks.
Yeah, I would just echo Nestor's comments that TriCore is working with all of our partners including the state lab, to send positive specimens for sequencing so we can monitor these variants.
Thanks, Cecilia. Thank you so much for those great and showing us that slide. That was really a helpful review. Elaine Gush, Dr. Gush reminded us about the case that Leslie presented. And I'm wondering, Nestor, if you or any others want to maybe remark on that clinical question, Nestor.
Yeah, especially the second patient, the one that's fully vaccinated, that has respiratory symptoms, and has a negative test. I mean, the risk of that person having infectious COVID, in my opinion, is very low. Because she's vaccinated, so at least she has some degree of protection from her 2 vaccines. And then on top of that, she has a negative either PCR or antigen, which translates into a very low risk of transmission. So unless, you know, something else is going, I wouldn't advise her to quarantine. You know, tell her to be careful, but I wouldn't force her to be at home for 14 days or for 10 days because she has a negative test. She's fully vaccinated. She's fully immunized. So I think the risk of her transmitting to other people is probably not 0, but it's very, very close to 0. It should be very low. That's my opinion. Even I haven't seen that statement clearly written in any, but I think the risk is low because, you know, the chances of her having transmissible COVID is probably less than 20%. And then on top of that, you put the fact that she has a negative test. If it was done at the right time, it's also a strong negative for transmission.
Thank you, Nestor. I'm wondering if Alexandra Cazares wants to unmute and ask the question about her case, 73-year-old female. Alexandra Cazares?
Sure, yeah, I'm here. Yeah, can you hear me?
Yes.
So I have a 73-year-old woman who, she has minimal medical problems, but maybe she's on a little bit of gabapentin, but she had her vaccine and a week later, she got diarrhea, tons of diarrhea, kind of mild abdominal pain, super fatigued, didn't eat for 6 days, lost 6 pounds. She still has loose stools, feels really fatigued, and she's due for her second COVID on Wednesday. She never had COVID. She and her husband don't go anywhere. Her husband wasn't sick. Should she get it? No?
Yeah, I mean, my opinion, this is one of those cases that you have to really individualize. You know, severe prolonged diarrhea is not a common reaction to the vaccine. It's definitely not an immediate allergic reaction. So I would give her the second dose. I would try to study why she's having diarrhea, see if I can figure it out. But I mean, you know, without seeing the patient, my recommendation would be to give her the second dose because the protection that the 2 vaccines confer are probably greater than the risk of having her diarrhea, worse. So I would say yes, but obviously it's you need to individualize these out of routine situations, right, or unusual situations. One concern for me would be that does she have COVID? But you said she had very small risk factors for that. So.
Thanks, Nestor. Leslie, do you have any thoughts on this case?
Yeah, just what Nestor already said, which was that I would definitely think about testing her for COVID. I mean, even if she, doesn't have any risk factors, I have definitely heard of people getting COVID while getting the vaccine. That was the only time they could have been exposed. So.
Right.
Yeah, and just to support the first case that Leslie presented, I mean, if you have a person, even if it's a vaccinated person with COVID and has risk factors, and I wouldn't hesitate in giving them the monoclonal if it's indicated otherwise because of the risk factors. You can always, if they're missing the second dose, you can always put the second dose later when the half-life of the convalescent, of the monoclonal antibodies wear off, which is around 3 months. You can put the second dose later. if need be. But if I have an 80-year-old with COVID, even if they got the first dose, I would just offer them the monoclonal to try to decrease hospitalization and severity, like nothing has happened. And like an unvaccinated person, I would give it to them, and then think about the second dose later. But after she passes this COVID crisis, we'll think about when to put the second dose, and probably I will just space it 3 months to wait for the half-life of the monoclonal to wear off, and I can then give her the second dose and get that booster effect. That's what I would say. But I agree.
Thank you.
Also, while we're on that topic, I ended up talking to Marla about it. And if you could just comment what you were telling me about the cases that there have been of breakthrough COVID among vaccinated people, just because I thought that was interesting.
Yeah, sure, happy to, and plan to talk about this more next week, where I have some more data and some slides I can share. But you'll remember that several weeks ago, we began routine surveillance for post-vaccination infections. So people who were beyond 2 weeks after their second vaccine who went on to test positive. And the numbers I have are a couple weeks old now, but through our surveillance, we had identified, I believe, 117 vaccine breakthrough cases. Again, not unexpected. We expect that some people who are vaccinated and then have exposures will go on to test positive. So far, that number has been low that we've picked up through this routine surveillance. And none of those cases have been attributed to a variant of concern. So they've just been sort of, the normal virus. So that's reassuring. And again, it's a small number.
Thank you, Marla. We're looking forward to seeing more data on this. Really appreciate that. Jeff Miller says he has a patient in the hospital with significant Guillain-Barré syndrome with the only known risk of COVID vaccine about 2 to 3 weeks prior. And the hospital neurologists are anecdotally stating that they've seen and heard cases they believe are related to COVID, and wanted to see if you've seen any supporting data on this, either Marla, Cecilia, Leslie, or Nestor, or anybody else for that matter, that we've seen, with the influenza vaccine and other vaccines that can cause Guillain-Barré.
Yeah, if I remember correctly, in the trials, there were a few cases, and they were there was not an imbalance between the number of cases of Guillain-Barré in the vaccine and placebo arm. There were like 4 and 2, 4 and 1. So respected for the number of subjects that entered the study and for the time that the study lasted. But it has been reported with COVID, with natural infection. And I wouldn't be surprised if it's reported also with vaccine, but it's an really infrequent event, and it doesn't seem to be much more common than the general unvaccinated population or placebo arms. That's as much as I can say.
And that's what I've heard too, Nestor. And then Cami McKinney has a question. Do you consider a person who was tested positive with the rapid antigen test, yet negative with the PCR test on the same day, positive or negative for COVID-19? Where can I find supporting documentation on how to determine which holds more validity?
Hi, this is Marla. Sorry, I put answer to this into chat.
Oh, you did.
And
Right.
There's an algorithm that CDC has to try to sort of help make this clinical determination when you have these discordant results. Part of it depends on the clinical presentation of the patient, and then also your pretest probability. When you go to this link and you first look at the algorithm, it seems very daunting and overwhelming. So I would just tell people sort of stick with it, because as you read down, it kind of walks you through using the algorithm, and that can be quite helpful.
Thank you. Cecilia, do you have any other thoughts on that?
Yeah, I would agree with Marla that CDC has algorithms. In our experience, the antigen tests have been less sensitive than a PCR test. Great,
thank you. We're getting close to near the end of the hour. Pamela DeFern talks about the local pollen counts related to, this is the time of year when we all get seasonal allergies and patients have URIs, and so it can be difficult to assess symptoms for symptomatology for COVID versus, regular URI symptoms. And I know we had a problem kind of with that last year. Diana Rodriguez Hurtado says, what was the worst adverse event after vaccination and the frequency? Nestor or Marla, do you have any kind of data on, what have been the kind of the more serious vaccination reports, either in New Mexico or kind of CDC reports from the US?
I mean, for me, I really don't know for sure which one is the most. I guess the immediate life-threatening anaphylactic reaction I would put number one, that have been clearly associated. Is an infrequent event, one in millions, but it's there for both of the mRNA vaccines. I would say that's the most severe adverse event that I have read about, but I don't know specifically if there are any other. I remember earlier in the vaccination in Finland, there were the report of 13 frail elderly subjects who die shortly after, but I think the autopsy reports and things are not being published to say if they were in any way associated with the vaccine. But that's what I would say. Allergic reactions, immediate allergic reactions, I would say are the more severe right now.
And Nestor, this is Joanna. Has there been any more data on the central nervous system venous thromboses from the AstraZeneca or?
No, what I have seen published are more like explanations of what happened. There's a description of these thrombocytopenia and circulating autoimmune antibodies. They're trying to come up with like the pathophysiology more than anything. Although AstraZeneca and some other people have really said that the frequency is so low that it's similar to what you expect to occur in the general population. But in those specific cases that reaction occurred, there was sort of a DIC-like picture with thrombocytopenia and other specific findings, and they're trying to figure out the mechanism. And I saw a German researcher pre-publication talking about autoimmune antibodies and that could explain the thrombocytopenia. Something similar to what we see with the heparin-induced thrombocytopenia or DIC. So they're trying to figure out the explanation for this phenomenon that I think are probably going to be related to the generation of immune reaction to some component of the vaccine that cross-react with platelets or something along those lines. But I think we need to wait to see more complete story of the explanation.
Thank you, Nestor. I just might ask Leslie or Marla or Cecilia if you have any last thoughts before I let people know about other ECHO clinics this week. Okay, wanted to let everybody know that we have a first responder ECHO at 2 o'clock today, Mountain Time, in just an hour. It is about resiliency in psychiatric emergency rooms and the high incidence of methamphetamine and how to take care of it, and kind of during this year with the kind of increased substance use disorders throughout the state of New Mexico and around the country. And that's at 2 o'clock. On Wednesday at 10 o'clock Mountain Time, we have the 7th of our 8-week series in climate change and human health. And that we have the Dr. John Balbus, who directs the National Institute of Environmental Sciences, talking about extreme weather events, like the weather event we had in Texas a few weeks ago, and Paul Schramm, who leads the climate change and health program at CDC, talking about disaster preparedness. That's Wednesday at 10 a.m. Mountain Time. And then on Thursday morning, we have the critical care echo with Michelle Harkins. And then Thursday at 12 noon, we have the substance use and chronic pain echo. So the CME is in the chat at 45 minutes after the hour, and it just went into I think it's going into the chat again right now. The slides are in the chat as well. And thank you very much for participating and for being a great network with us. And we'll see you all next week, and stay safe.